All right, can everyone see that okay?
Yes.
Perfect, thank you so much. All right, Robin, we are ready for you. Whenever you're ready, we're on case ID 1045.
So this young man, 30 years old, black man, diagnosed in 2017, and treated in 2018. Then he contracted hep C again. He's currently in one of the rehab programs at Southern Highlands. It's a long-term treatment program. He did have like an abnormal EKG, and so I sent him to, when I say abnormal, he just had some ST elevation, non-specific changes. Sent him to a cardiologist, and he said everything is fine. So he does smoke. He started using IV drugs in his early 20s. So he's got vitamin D deficiency. He had some palpitations, for which he's taken metoprolol, and IV drug use, of course, and substance abuse. So, all right, then his relevant labs. I saw that you reconfigured these. Are we doing to condense? Is that why we're doing this? Do you want me to go through labs and
Give me one second. Oh, the lab's not there. I'm so sorry.
Okay, but I have some written down.
Okay,
so
please do. Yeah, I'm sorry.
I'll just touch on the ones that are relevant, I think. So his liver enzymes were elevated, but not significantly. His APRI score was 0.673, MELD score was 8, and his child Turco-Q score was 5. He's a class A. I think he's a relatively simple patient. He's immune to hepatitis A and B, and he has genotype 1A. And I feel like Maverick for 8 weeks is going to be an appropriate treatment for him. I don't anticipate needing follow-up, but I want to verify that if I need to do hep C testing after the initial 3 to 6 months. I do one after 3 months, and then again after 6 months anyway on everybody, but maybe should recommend if I do it more or not. So it was a simple case.
No worries. Thank you so much. Does anybody have any questions or need any of the labs said again?
Hey, Robin, this is Kaylee. Do you know what he was treated with in 2018, and if it was for sure a reinfection, or if there's a possibility maybe he didn't finish the treatment?
Well, he said he finished it and then he got it again. So I don't know what medicine he was on. I'm sorry.
No, that's okay. That's okay. The reason I kind of get a little bit fixated on that is just it would change management options if he was a treatment failure or maybe didn't complete the full course of treatment previously. Since it was 2018, he likely wouldn't have been treated with interferon. It would have been one of the direct acting antivirals. Yeah, so I'd be a little bit more concerned if with that than if he for sure, said, yes, they told me I was negative. And after I was treated, I was still negative, and then for sure was reinfected. So if he maybe didn't have any follow-up lab work after that last treatment, I try to kind of clarify a little bit more what the scenario was, and then even, what might be different this time. So, if he was already reinfected once, what strategies is he going to do this time to make sure that doesn't happen again in terms of harm reduction? How long has he been in recovery now?
He's been there for a couple of months, and he's for the long-term program, so he'll be there at least 90 days. So his treatment will be initiated while he's still in the recovery program.
Okay, I gotcha. Yeah, I think probably the biggest thing I would focus on with him is just, what's going to change this time so that he doesn't get reinfected a third time. And I may be a little bit more, I don't want to say hesitant to treat, but a little bit cautious to initiate treatment or retreatment too quickly, and that just in case he will get lost to care long term. Do you have a fibro test on him, or an
yeah, he has no fibrosis. He's a F0.
Oh, perfect. Okay. Okay. And then what about medications? Is he taking anything currently? I didn't get to see
Yeah,
a med list.
I didn't have that on the paper, but he is on Buspar,
Okay.
hydroxyzine, metoprolol, Suboxone, trazodone, and I have him on vitamin D replacement.
Okay.
Oh, and
Okay.
also
So
ariprazole. But he was taking some, I'm sorry, Imodium. So, but that was just a PRN. He doesn't take that routinely. I think that would affect his treatment, wouldn't it? The Imodium is one thing that we have to make sure they're not on.
Imodium would be okay. Actually, Rachel, correct me if I'm wrong. I don't believe that there's any interactions. It would be more if it was like an antacid or PPI, anything like that. But I don't think any Imodium would. But yeah, so if everything pans out and he does seem pretty engaged in care and kind of understands how to avoid getting a reinfection again, and is pretty confident that this isn't something that is a treatment failure, incomplete treatment, then Mavorite for 8 weeks would be perfectly fine. There's no drug interactions with that, as long as he knows to take it with food. That would be the other thing.
Okay.
All right. Thank you.
Awesome. Thank you so much, Kaylee. Does anybody else have any questions or comments for this case?
I was going to touch base a little pyramide, just like Kaylee said, if you're sure that it's just something that he's taking PRN, he's not doing it regularly, there's not really any concern for that while he's taking the Hep C treatment. The only other thing to mention, and I don't see Angie from RDT on here, it's my understanding now, the way that what we've experienced with doing the authorizations for these reinfections or retreatments is they do have to be reviewed by the medical director. So what you're going to do is submit it, and then RDT is going to immediately deny it and send it back to you. So you might as well just kind of get ready for the appeal process, which is just writing that letter of medical necessity saying, that all the things that you have already talked about with Kaylee here, that, like his treatment and the plan for how you're going to make sure that he stays on track and how he's going to stay adherent, that he's going to follow up, those sort of things, just to kind of prove medical necessity and that the patient is kind of dedicated for treatment. So just kind of don't be surprised when you submit it if they automatically deny it, because that's their process now is for reinfections and retreatment. It needs to go to Charleston.
Great. Thank you so much, Rachel. Robin, do you have any other questions before we move on to your second case?
I don't think so.
All right, I'll get that one pulled up. Maybe. All right.
So the next case is a 31-year-old female. Her boyfriend is actually currently in treatment as well for hepatitis C, but she started using at the age of 23, mostly heroin and meth. She currently still smokes marijuana, but she reports she doesn't drink any alcohol. In 2020, she was pregnant. That's when she initially got diagnosed. And her baby's 18 months old now. And we have talked to her. I've talked to her about having the baby tested again. And she was supposed to bring him in to me, but I've not seen that baby yet. So, I think with 18 months old, I think I probably need to test that baby. If I remember correctly, at least now, and then maybe again about 6 months from now. But anyway, that will treat him or test him at some point. She smokes. She currently has an IUD in place. She has been clean for nearly a year now, and she's enrolled in the Suboxone program here at Southern Highlands. So, right there on the comorbidities, I don't think that that's correct where it says Hep B core antibody present. She did not have a core antibody present. She is currently receiving her hepatitis B vaccinations. So that's not correct there. Relevant labs, normal white blood cell count, everything looked okay down to her APRI score is 0.225. AST and ALT were normal, well, fairly normal. The ALT was a little bit high. Her child Turco-Q score was, she's a class A, and her MELD score was 6. She is also genotype 1A. I mean, I feel like that she's fairly motivated to, to follow through with her treatment plan and stay clean. She's done well, and I think her baby made a big difference in her social status. So I think that she's, kind of determined now. I feel like Maverick would be her best option as well, because at 1A, I think that'll be cut and dry. I don't think there's any significant interactions with her medications. She is on the omeprazole and a PPI, so that's the only one that I would see any issue with at all. But I think it'd be okay with the Maverick. So that's it. I just want to verify with you guys that Maverick for 8 weeks would be appropriate treatment.
Thank you so much for that second case. And again, I can always bring everything back up if you guys need it. Are there any questions?
So it's Kurt for ID in Morgantown here. So I was just kind of reviewing a little bit. I worry a little bit about the interaction between the Lipitor and the Maverick. I'm not sure, Rachel or Kaylee, if that's something that needs to be held while the patient's on Maverick.
Yeah.
Yes,
So
Kurt. Go ahead, Rachel, because
Sorry,
you're way
Kaylee.
better at this than me. No, go for it, girlfriend.
So for the torvastatin, those statins are always the pesky ones that become the problem. So with Maverick, they're contraindicated totally. So there's no dose of the Lipitor specifically that's going to be okay to give concurrently. The difference would be the Epclusa, where it just is a monitor for those additional kind of myalgias and side effects, because it increases the concentration of the statin. So what you could do is just hold it for that 8 weeks while she's taking it. You could change it to another statin. I'm never pro that idea, just because patients get confused and then the pharmacy is confused on which one they're supposed to be dispensing. So if she doesn't have a significant cardiac history where you're worried about her being off that for 8 weeks, that's usually your best option if you want to go with Maverick, just to have her hold it.
Okay, I'll do that.
Yeah, because like you said, with the omeprazole, that dose is too high to use with the Epclusa as your alternative treatment.
Okay. I'll just hold the statin on her then.
And I just want to chime in too. This is Kaylee again. I know with our Medicaid patients, it's Epclusa and Maverick that are the two preferred, but just remember, we also have, if we kind of took away that formulary restriction, then Harvoni for 8 weeks would be reasonable with her too. That's just for learning purposes or teaching purposes. The Epclusa and the Harvoni would both interact with the PPI that she's on, so ideally would need to be held. But and then the statin, like Rachel said, would just need to be monitored with either of those. But just remember, we're not really, using Harvoni as much anymore, just because it's not on Medicaid's formulary, but it is also an option as well.
Okay.
And good job with remembering to test baby at 18 months. Yes. So
what's the guidelines? Should I test the baby long term as well?
Nope. So unless there's any kind of concern about a blood exposure to mom, but or I guess to dad too, since he's also positive. But 18 months is the threshold. Just do an HCV antibody screen. Sometimes they'll screen the baby at birth. And so if that's when you would do the repeat testing at 18 months regardless. But by that point in time, if they shouldn't have any maternal antibodies left over. So if they're truly negative, they would be negative by 18 months.
Now, does this program, if that baby were positive, would I be able to treat that baby through this program or no?
So treatment is approved as early as age 3. And with treatment in pediatrics, because I don't do pediatrics, but we do have some peds ID folks here, and so you could always refer to them or consult with them about treatment. Typically, kind of as far as little ones treating, because they're not really great at taking meds anyway. So I mean, it would be reasonable to monitor them for a while, and then when they're a little bit older to consider treatment. But they do. And Rachel can correct me. I'm not sure about Maverick and the little ones, but they do pellets. They have like Harvoni, and I think Epclusa now. Pellets is how they give it, or a liquid form as well. But not until they're 3, at least 3.
All right, well, let's hope it's negative, but I just.
Yes,
wanna
I
play that
hope.
up here.
It's only, I mean, it's about a 6% chance. And so sometimes a little bit higher, but overall it's low risk. So you can reassure mom of that as well.
Okay. All right,
What-
thanks.
What I will chime in and say with the pellets, because we do have some kiddos that go through here. So both the Epclusa and the Maverit are available in pellet form. Just as a quick thing, and I can throw this into my presentation for you guys if you want me to do that for then I think the next one on the 11th that I'm doing. But the pellets themselves, so Epclusa comes in different doses of the pellet. So you can go ahead and, they're doing 1 packet of the pellet that they have to do, but the Maverit actually only comes in 1 dose. So based on the kid's weight, you actually might have to do more than 1 packet per dose. And packets for both of these drugs taste awful. So I have a lot, I can probably count of the, maybe 10 or so that have gone through here. I can probably count 2 or 3 that have actually successfully completed treatment that are under the age of 5. So that 3 to 5 range, because they taste so bad and parents have so much trouble trying to get the kids to take them, and even the different, they've only tested them in a limited amount of food. So, if mom and dad are okay with waiting until they can swallow tablets at like 5, 6 years old, that's usually what I say to go with, just because most of them will send them their first month and then they can't tolerate it after a week or so and then they stop.
Go ahead, Kurt. Thank you.
Oh, hey, thanks. Kurt again. I'm certainly a novice at this, and but just based on some discussion I had with Dr. Gilfus yesterday, he specifically was, and now I know you had told us that it was just an error that the hepatitis B core antibody was positive, but that was a particular worry of his, where it isn't impossible that could mean the patient had acute hepatitis B or was like in the window period there where it actually could be not, but if that's not the case, that's great. I know he was harping on the fact that if they had hepatitis B surface antibody positive, then that would assuage all his fears.
Well, I mean, I looked back on that because usually if their hepatitis B core is positive, I'll go ahead and get a PCR, a hepatitis B PCR. And hers, it was negative. So I don't know how that got in there. So I apologize for the confusion on that one.
Oh, no problem at all. Great. I'm glad that we don't have to worry about that. Good. Thank you.
Thank you so much, Kurt. And Dr. Gilfus did message me recommendations, and we'll include those in the cases too. He was going to have some service issues, I think, today. So, all right. Are you good, Robin? Perfect. Thank you so much for those. All right, Gary, I'm ready to do yours. You ready?
Can you hear me?
Yes.
Okay. So this is a 62-year-old man. I had some trouble getting his full history, but what I could gather, he was diagnosed with Hep C about 15 years ago. He said that he got it through a female sexual partner. He is bisexual, but he said the one lady he did sleep with, she told him later that she had hepatitis C. He said he's never done drugs. He has no tattoos, no piercings, no transfusions. He does have some social alcohol use, but not any abuse, and currently does not use anything. His exam was normal. His ultrasound showed increased architecture of the liver, but no lesions. The spleen was normal. His elastography was F2. He has a history, you can see it there, of allergies, anemia, COPD, depression, GERD, hypertension, PAD, and vitamin D deficiency. He's on these medications. I forget the list. He's also on sertraline and vitamin D and albuterol inhaler. He is immune to hepatitis A, but not B. His vaccine, the vaccines were started. He weighs 141 pounds, BMI is 19. Most of his labs were normal. His platelets was 328. His APRI score was 0.3. Child is 5A, and adult score is 6. He is genotype 1A, serum fibrosis marker was F1, F2. So I think the medications are okay. And I'm assuming Maverick would be okay for this.
Great job. Thank you so much, Gary. All right. Anybody have any questions or want to go into the recommendations?
Kurt, you want to do this one or you want me to?
Oh, you can take it from here.
But I want you to. Thanks, Gary. You're correct. I mean, you could do Maverick, and again, it's kind of going to depend on his formulary, and Rachel might be able to help with that since he's Medicare or UPMC. I'm not always sure with their Part D plans what's preferred. It kind of varies, but technically, treatment options with him, you could do Harvoni times 8 weeks, or yes, Harvoni times 8 weeks. So Harvoni times 12 weeks is generally recommended, but in certain cases, we can do a shortened course. That's if the patient is HIV negative, treatment naive, has a viral load of less than 6 million and is not cirrhotic. And so he would meet that criteria, so he could technically do a shortened course if that's on his preferred list. Also, Maverick times 8 or Epclusa times 12. It does not appear that there is, with the medications listed, the only one potentially is that famotidine, which if he could hold that would be best. But otherwise, he could, if he was doing Maverick, there's not any interaction. If it was Epclusa or Harvoni, there are a little bit of administration or dosing adjustments to be made if it can't be held. The other thing I want to point out is, since he was pretty certain his risk factor is through unprotected sex with a female, the other things I might want to ask him, just because this is for my own interest too, but in terms of risk factors, is if he has any military history. There's possibility, if he had undergone any kind of air gun immunizations in the past, that's also a transmission factor. And sometimes kind of when I see patients that are in their 60s or and up, considering that, possibly even through like a healthcare procedure, dental work, from a long time ago, might have actually contracted it through blood exposure that way as well, or in addition to occupational exposures. But I always like to ask that military history. It sounds like he's had this, for a long time, and I kind of want to know, what led to him getting tested that long ago. Was it transaminitis or unfortunately, we weren't really doing just routine screening for Hep C at that point. So I would want to know kind of what prompted him to get tested, but won't change your management, just something to talk about with them.
Thank you so much. Rachel, did you have anything to add, or Gary, do you have any other questions?
I don't.
Yeah, I don't really have anything to add. Kaylee covered drug interactions, and I unfortunately am not going to give you any guidance on formulary because there's so many different of those UPMC for life plans that without really knowing which plan they have, I don't know what they're going to cover. So you'll just have to see when you.
Sorry, I've had good success with Maverick with UPMC, so I think I'll just do that again.
Yeah, sounds reasonable to me.
Thank you. All right, and then we'll pull up this last case.
So this is a 37-year-old female. She has a history of IV heroin use and snorting opioids. She did share paraphernalia. She thinks she was around 21 when she first started, so about 16 years ago. She said she started with opioids first and progressed to heroin use. She's been clean for 11 years. She did go to rehab and she still attends weekly meetings. She was first diagnosed with hepatitis C about 8 years ago. She has never been referred or treated. Her husband is also hepatitis C positive without treatment. He is supposed to be scheduled with me so we can discuss his treatment. She has a history of asthma, GERD, opiate dependence. She smokes and vitamin D deficiency. She's on doing a omeprazole, vitamin D, and Subutex. She is not immune to Hep A or Hep B. Both those vaccines have been started. Her BMI is 36. Her platelets are 261. Her LFTs are okay. APRI was 0.4, child was 5, Mel was 7. And she's genotype 1A. Her vitamin D was a little bit low, but she's on replacement now. And her fibrosis biomarker was F0. And I did get her ultrasound results after I submitted this. It just showed mild fatty liver disease, but everything else was normal. I knew there's going to be interactions with the omeprazole.
Thank you so much. All right, we're ready for the questions and recommendations.
Go ahead, Kurt.
All right.
No pressure. You got this.
Oh, yes. So
All the pressure in the world. All the
I
pressure in the
know,
world.
right? Woof. So it's very likely you know how to treat hepatitis C better than I do, but nonetheless, I at least have a sneak peek into some of the recommendations. I think first and foremost, obviously, you're doing everything right with getting them vaccinated against A and B and doing the old vitamin D replacement. And then we did too. It's great that you're bringing the husband in to get him treated as well, because although the risk isn't very high with heterosexual contact, it is certainly not impossible for him to give it back to her after she's treated through sex. And so let's see here. What else? Yeah, Dr. Gilfus was and I concur that Mavorite or Epclusa would be the choices in this Medicaid patient. There seemed to be the significant interaction with Epclusa giving that with the PPI. So that would be an issue. Now, does Mavorite have an interaction with the PPI or not?
Nope, it does
Okay,
not. Just
Okay,
nope,
so
nope.
so that is good news. As here he is mentioning that there is it's kind of like the whole doxycycline with your vitamins thing. You have to give them this complex story about how to take their Epclusa if they really need their omeprazole. Take it food 4 hours before the omeprazole or not. I think that the Mavorite in our opinion would be the best choice for this woman, and great that bringing her husband in, or else she could end up getting it back from him again in another way.
Thanks, Kurt. The only thing I also want to add, Gary, too, is she on any kind of contraception right now?
She is not, but they do
Okay.
use condoms.
Okay. So the only thing I would point out, so if she was on contraception, just remember for everyone on the call, with our women of childbearing age, if they're on any type of ethinyl estradiol containing birth control method, then that's actually contraindicated with Mavorite. So in her case, she's not on anything. Condoms is fine. But just kind of keep that caveat. I usually do a pregnancy screen, even if they're like, oh, I haven't been sexually active for a while. I still kind of like to get a baseline one, just since we technically don't have any treatments approved with pregnancy.
Okay.
But otherwise, man, go for it. Mavorite for 8.
Thank you so much, Kaylee, and great job, Kurt. Thank you very much. Any other questions or comments? Gary, do you have any further questions?
No, thank
All
you
right,
for your help.
thank you, of course. Does anybody have any comments or questions regarding their own patients? We do still have a little bit of time, or I can give you some time back. All right, do the nice echo pause here. Well, I really appreciate every one of you. Thank you so much. And our next session is going to take place on August 11th with Rachel Mitchell discussing psychiatry medications and drug interactions. So that should be a good one. And I just hope you guys have a great rest of your week. Thank you.
Bye. Thank you.